we're obviously not bashing this article.
Yeah.
I do think we're doing our due diligence and like providing perspective that's maybe, I don't know if it's the unpopular opinion, it's like the opinion that no one realizes they should consider. Welcome to Feasibility Clinic, where we put the club in Journal Club. You can find me in the club, bottle full of bub. Hi, I'm Dr. Stephanie Van. I'm a pain management specialist and I mess it up every time. I'm a young Vietnamese female with long black hair, wearing a black velvet blazer and a black blouse, white pearl earrings, against a very boring white background. Today, we're going to talk about an article that just dropped in Nature, arguably the most legit journal in all of medicine. So the research we'll be discussing today claims to demonstrate that electrical stimulation of the spinal cord can help people who are paralyzed regain significant motor function in their legs to be able to stand and walk again. This study represents the most cutting-edge experimental medicine in spinal cord injury recovery, but it doesn't acknowledge the very effective and readily available strategies that are already proven to help patients with spinal cord injury, or SCI. So like any good journal club, we'll be discussing the strengths and weaknesses of this research. Joining me today is my colleague, Dr. Donna Huang. Welcome to the show, Donna.
Thank you. It's so great to be here.
How do you usually introduce yourself to new people when you meet them?
I am Dr. Donna Huang. I am a physical medicine and rehabilitation physician. On top of that, I also subspecialize in spinal cord injury medicine, and I am practicing in Texas. I am a Chinese female with mid-length black hair, wearing a navy blue blazer and a cobalt blue top against a blurred background because I actually have a very messy kitchen and living room behind me.
Nice to meet you.
So the title of this article is Activity-Dependent Spinal Cord Neuromodulation Rapidly Restores Trunk and Leg Motor Functions After Complete Paralysis. So that's a bit of a mouthful, but it essentially does capture exactly what the authors were meaning to investigate.
So it sounds really exciting, right? Like the whole premise of the study is, people who are paralyzed and can't walk after a spinal cord injury, they're proposing this new high-tech implantable strategy to help people walk again.
The idea was that in individuals who have paralysis, essentially that it could restore their voluntary leg motor functions, as well as some of the functions in the muscles that control their trunk.
So this research is the result of work that started many years ago by a group in Switzerland, led by Dr. Jocelyn Bloch from Lausanne University Hospital and Gregoire Courtine of the Swiss Federal Institute of Technology. The base article is about 10 pages, and that includes a lot of pictures and figures. And then there's about 30 additional pages of supplemental data and figures to dive into. But don't worry, we're going to break it down for you. So if you do find yourself reading the article or ones like it, it'll be easier to understand.
Spinal cord stimulators in America in particular are primarily used clinically for the management of pain. It's essentially electrodes that are implanted near the spinal cord and provide electrical impulses to modulate the function of the spinal cord.
They involve a couple of procedures. You kind of have to do a test trial first where the leads are implanted to see if they work. And usually they stay in for about a week. And if they work well, then you go for another procedure. It's not permanent necessarily, like it's obviously reversible, you can take it out, but the impulse generator, the battery pack, is then implanted under someone's skin and the electrodes are in their spinal cord essentially, or in the epidural space. And unfortunately, some of the pitfalls of this is that it's a foreign body. So there's a risk for infection and there's a risk of hardware failure. And word on the street is that after a couple of years, as the nervous system kind of gets used to that extra stimulation overriding those pain signals, it stops being as effective. And unfortunately, a lot of people have to get these stimulators taken out because they stop working. It's not a perfect strategy for pain already.
In research and in experimental models, for quite some time, people have been exploring the usage of electrical stimulation in producing changes in motor function. Typically, spinal cord stimulators stimulate the dorsal column, whereas this is designed to stimulate the dorsal roots.
The way they started this study, they wanted to make sure they were putting the electrodes in as specific a place in the spinal cord as possible to stimulate the motor function in the legs. So they actually took like a bunch of imaging studies from healthy non-spinal cord injured people, and they also took measurements in cadavers to kind of get an average human spinal cord. And that helped them map out where on the spinal cord are those motor nerve roots distributed so that they could plan for the electrode placement accordingly, which I thought was, a good start.
Yes, absolutely. That particular approach, I think, was also an innovation on some of the studies that have happened in the past, and that they were really trying to hone in on the actual distribution of nerves that control the functions that they're interested in.
They had 3 research subjects, which is a very small number, but considering how intense this research project was, it's kind of understandable that they only had the resources to accommodate 3 people. At least it wasn't just one person. So for each research subject, they took them into the operating room, they scanned their individual spinal cord, and then they continued to further tailor the placement of the electrodes intraoperatively with imaging and also with intraoperative stimulation. So they would send signals through the electrodes as they were placing them surgically to really try to maximize the motor response in these patients' legs. Okay, so one of the things that gets people really excited in this study is that the researchers claim post-op day 0, like the same day these patients got these stimulators implanted, they claim that these patients were able to produce some sort of natural gait pattern immediately after receiving the implant. But the caveat is they received substantial support from a body weight support system and they were with physical therapy. So it's not like they just got off the operating table and started walking.
Right, exactly. After the participants underwent the surgical implantation of the devices, they then went on to participate in a rigorous 5-month neurorehabilitation program. The participants were able to achieve improved trunk control and participation in leisure activities, including boxing, being able to stand for prolonged periods of time, such as drinking at a bar with your friends, paddling a canoe.
I feel like we're getting to this part of the article where the results are all sexy sounding, but both of us are getting a little bit kind of angry.
I'm always angry.
I think when I read this, there were a few things that there certainly are impressive. The time course of the ability to produce voluntary motor movements after implantation, that is impressive. The functional gains that particularly one of the participants gained after the 5-month neuro rehab course were also impressive. It should be specifically noted that in a lot of the media coverage of this, it says that the individuals were able to walk independently, which produces an image in most folks' mind that they were just able to walk completely without assistance. All of the participants, if they were ambulating at a community level, were using an assistive device, a walker, which still is a lot more independence or agility compared to the use of a wheelchair. But it should be specifically noted that they weren't, their gait pattern and things like that were not just that of someone who does not have a spinal cord injury or doesn't have a spinal cord stimulator implanted. There were many things as I'm reading this that are, almost a bit kind of bittersweet in the sense that what it would take to make a technology like this implementable, there's just a huge gap. And I think most people don't understand that. And also it's just something that's never really discussed. You wouldn't really expect that in a scientific article published in an academic journal for them to get so much into that. They mostly focus on sort of the technological and scientific and experimental progress that would be needed. But really there's so many more layers beyond that would really inhibit this from ever being a widespread practical technology to use for a lot of folks.
Yeah, one of my other colleagues actually just asked me about this yesterday. And she asked me, what happens when patients ask me about this? What am I going to say? What would you tell a patient if they were like, Dr. Huang, can I get this?
Regulatory barriers honestly make that answer easy for us. And I say that this type of technology has been studied in various ways for spinal cord injury for quite some time. And this is kind of the newest innovation on that. This specific device was developed in Europe and is not even widely available in Europe, but only available in the context of research. If they have more questions, or if, for example, they're very, very keen to figure out whether they could get involved in this type of research. Obviously, whether this is right for someone is a very individualized decision. Truthfully, I think the folks that are in the research that know the most about the technology and about the program would also be the most appropriate people to kind of talk to people about patient selection and the details of the risks. Yeah, that's generally kind of my spiel about this type of research.
That's good, because it sounds like you're helping to manage their expectation and give them a realistic picture of the reality of where this is happening and how unavailable it is right now. And I feel like it's also an opportunity to bring up all the other things that they can control and they can do right now. There are many strategies available to people with spinal cord injury to improve their function and quality of life. And if this becomes like a motivator, like, oh, I need to optimize my health as someone who's paralyzed to become a candidate for this research, it doesn't matter what's motivating them. They have the right goals. We talked about how not only did they implant this novel device with an extensive new surgery technique, but they're also putting people through 5 months of rigorous therapy.
So just to kind of give some context as to what typical rehab looks like, right after you have your injury, you usually go to inpatient rehab, 3 hours of therapy a day, 5 days a week, typically. And the length of your rehab can vary. These days, I think we're seeing on average about 8 weeks. Once you're in the community, rehab allowances based on insurance are usually something on the order of 12 visits in a calendar year. And experimental rehab in this case was, 5 months of intensive therapy, 4 to 5 days a week. So
yeah, that sounds real expensive.
Most insurance would simply be unwilling to pay for that. And, some folks are lucky to have resources and they can private pay for that type of thing. But there's also just in terms of, whether folks can even get to a center to participate in rehab at that level. A lot of people had a really hard time continuing their participation in those trials because it involved going to a hospital that may be far away from where you live, may have challenging parking situations, may be very difficult to navigate 4 to 5 times a week and be there for several hours a day, which ultimately is very challenging for people.
One of the participants was a year out of his injury, which is, pretty recent. Who's to say that even without the stimulator, if he were put through 5 months of rigorous therapy, he could have continued to improve already. Like the nervous system can still be healing at that stage.
Right, exactly. And that is also a really big challenge of, well, frankly, all research and rehab interventions, because most of these or all of the studies like this involve a similar format, implant device, and have very intensive rehab. In fact, one of them even had several months of rehab before implantation and then several months of rehab after implantation. Was that likely on its own to produce the voluntary motor function that we've seen? No. But on the other hand, in good experimental design, if you can't control for those things, you don't know at the end of the day.
These 3 guys who were in the study, they were kind of in the young middle-aged category, right? They seemed otherwise healthy aside from their spinal cord injuries. They were 1, 3, and 9 years out of their injury. At baseline, the thing they had in common was they had no volitional and motor movement below their level of injury.
2 of them were Asia A, which means that they are sensory and motor complete. And one of them was Asia B, which is sensory incomplete. Even between A and B, just observationally and statistically, we know that there are subtle differences in the propensity for folks with an Asia B to recover function spontaneously compared to someone with an Asia A.
Yeah, and it's interesting because when we say complete in our minds, we think there's absolutely no function, no signaling, but below the level. Like that's the general understanding of these classifications. With the stimulation factor introduced with this research, in all of these subjects are producing some sort of gait pattern. And I think that really indicates that there are some intact pathways in the spinal cord. Maybe they're below the level of injury. Maybe they're not communicating with the brain like the rest of the central nervous system, but there's some hardware or like biological hardware that's communicating with this external hardware that is being stimulated like it hasn't ever been before. And I think a new term is kind of coming out in the literature that's kind of like non-complete instead of incomplete.
Yeah.
Have you heard
Yeah.
that?
I think that's really one of the things that spinal cord stimulator research, it's really kind of shifted or helped expand understandings of the actual physiologic function of the spinal cord. Traditionally it's thought that, well, once the communication between the brain and the periphery is disrupted by damage to the spinal cord, well, that's kind of it. This research has kind of shown that the spinal cord and its pathways are really quite a bit more complex than perhaps we understand. And we're only just beginning to kind of tap into those potential pathways.
What do you think about the research authors focusing on ambulation as one of their main outcomes?
Well, that's where I think my feelings about this research are complicated. I think, as proof of concept, focus on ambulation isn't important, but in terms of just kind of understanding disability, it's a little bit problematic. Studying technologies to try to reintroduce ambulation is kind of based on this very fundamental assumption that everyone needs to move in the world a certain way in order to be able to participate in a certain way. Most people understand that to be, well, the reason you can't participate is because you're paralyzed, so therefore you must need to walk. But it's really, the reason you can't participate in society is because there are social and built barriers, not because you're paralyzed. This is something that has a name. It's called ableism, and it's a structure like many structures that we have in society. This is something also that I am by no means an expert in. I'm only kind of just coming to understand more about this myself. Reading this research and kind of particularly reading the lay media representations of it really kind of tickled something in my brain about that. It's very, I think, scientifically very cool, but definitely a little insidious or honestly potentially harmful to talk about it as if this is something that is unambiguously the right thing for people with disability, and also that this is going to be a pathway to cure all of the supposed ills of disability, if that makes sense.
Absolutely. I mean, you're touching on the medical model of disability, which is what we trained under. That was kind of how we were taught, and that's the system that we're working in, is that people who are injured and living with disabilities need to be fixed to a certain extent. Like, we're trying to save people's lives, we're trying to help people live well. Like, obviously the healthcare system, no one's going to argue that that's what it's for. You're really touching on the social model of disability versus the medical model of disability. And these outcomes, of course, ambulation was the major one. They also looked at canoeing, and they looked at standing, and they looked at going to a bar. And like you said, that CNN article, the tone of it was as if people who use wheelchairs or who can't walk or who are paralyzed can't go to a bar with their friends, or like can't enjoy that as much without being able to stand at the bar, which is extremely ableist.
I mean, the undertone of that is that, like, it's the paralysis that makes those things inconvenient or difficult. And it's really not. It's really the built structures, like the environment and how we have tailored our world to people who are ambulatory, not, someone's legs not moving, that make those activities more difficult to do for someone with a disability.
So you're saying if we lived in a world that had more accessible universal design, there would be adjustable height bars everywhere, and there would be, Hoyer lifts at every boat dock and canoe dock so that wheelchair users could easily get in and out, which I've seen and could be available, but just aren't.
Yeah, and I think we say this, it's like we're almost, sort of not even able to say it with a straight face, because a lot of people, when you begin to kind of say these things, it feels a little like outlandish or silly. But I think that really speaks to the degree to which ableism is sort of ingrained in our thinking. How is having ramps or widened doorways outlandish compared to, talking about implanting a device and undergoing intensive rehab, right? It simply speaks to the ways in which, like, we allow ourselves to be imaginative about the world versus not. in thinking about people with disability, right?
I love that point, because we're talking about an expensive device, a risky operation that might help one person after 5 months of rehab, whereas a ramp or a widened doorway, that's an expensive architectural project that helps everybody who visits that building.
Right. Yeah, exactly. There's just such a big gap between what the American healthcare system actually provides for people living with disability and what would be needed to even make this type of technology feasible.
Sometimes our healthcare system does some things okay, it's not perfect, but like, thankfully, like you and I both have met many people who sustained spinal cord injuries, survived, and now are living like very fulfilling lives, walking or not, and some credit goes to the healthcare system for that. Obviously, a lot of credit goes to the survivors themselves, their families, their healthcare teams, their support systems. But I think you're emphasizing the fact that we can't ignore what's already working for people now with paralysis to live full lives.
And the reason I was kind of interested in having a more fleshed out conversation about this is because I feel like my perspectives on this have changed a lot, even in just a very short amount of time. I've now gone through medical school, residency, fellowship, like subspecialized in a rehab field. And I feel like of anyone, maybe like in society, I probably should understand these things. But even then, there's not a lot of formal education or discussion about this in medical school or any medical training, frankly. And so, a lot of what I've like come to learn and understand about this has been just sort of exploring this on my own through various, disability justice resources or just different people who have social media platforms that talk about this, learning about this and kind of beginning to understand and question your own preconceived notions about disability and the degree to which how much your sort of social narratives and biases are contributing to how you think about people that seem like on the surface very objective and medical and biological. I think just adds a layer to understanding research about this that is important. And I mean, obviously sort of complex and nuanced and isn't going to be in a CNN article. And so, I just thought it was kind of important to talk about that a little bit more and hopefully get some people to think about it a little bit more.
There are a lot of good groups who are very active in working on policy changes and curriculum changes on multiple levels. There have been a couple of institutions who've published papers on piloting a disability medicine curriculum. And the Alliance for Disability and Healthcare Education is a group that released some guidelines back in 2019, the core competencies on disability for healthcare education. Things are changing. And I'm really hopeful that disability medicine and anti-ableism is going to become a core competency across medical schools in this country and hopefully in the world one day.
Yeah, absolutely. Wholeheartedly agree. That pretty much sums it up,
It's a simple 10-page article, no big deal.
30 pages of supplementary data, like it's fine.
We're taught to be lifelong learners. So I feel like the fact that we're questioning our previous education and questioning our outlook and our current systems of healthcare, that's exactly what healthcare needs. It's funny because as a trainee journal club, like, I don't know about you, but for me, it just felt like such a chore. Like, no one loves reading scientific literature. It's usually quite dense and very boring and jargony, but picking it apart and kind of viewing it with, our patients in mind makes it a lot more palatable, and doing it with a friend is fun too.
Absolutely.
Do you have any sort of closing final thoughts or, big takeaways from this article and this experience?
Yeah, absolutely. When you see something like this and when you see assertions that it is going to be a miraculous intervention and completely change the landscape of what it is like to live with a disability or a spinal cord injury in particular. Like with any sweeping positive generalizations, you should consider, why that may or may not be. And I just hope that our conversation today maybe contributed a little bit of context and sort of depth into maybe some of the work that still remains to be done. I hope maybe it encourages some people to explore a little bit more about maybe just understanding the lived experiences of people with disability. Particularly, I think it's important to learn more about that from the perspective of people actually living with disabilities. I think in the age of the internet and social media, there's ample opportunity to do that, though there was before, as there have been activists and scholars in this space for a long time. I certainly have a lot more to learn as well. So yeah.
Lifelong learning. We're in it for the long run.
Yeah, absolutely.
Oh, I love it. Thank you so much for joining me. This was a blast. I never had so much fun reading a scientific article.
Thank you so much for having me. Likewise,
Thank you so much for tuning into this journal club and getting through all of it. We hope you enjoyed reading along this article with us. If you have any questions about what we discussed today or have a more in-depth question about the article's content, please leave it in the comments below. I will definitely get back to you. If you learned something from today's video, please hit the like button and consider subscribing to Disability Clinic for more accessible and educational content. I don't think there's anything else I need to say. Thank you for watching. You want to say bye to the people, Donna?
Bye, everybody. Thank you for watching. I'm a Chinese female with mid-length hair, wearing mid-length black hair with wearing. Oh my God. Okay.
It's okay. It's okay. I'm so glad you did that with me because I'm trying to get more used to it, because that's one of those social model of disability things. It's not that it's inconvenient to do audio descriptions. It's just that we don't think about it. And then people with low vision or who are blind don't get the benefit of imagining our beautiful faces on the screen.
Yeah, exactly.
All right. It is such a mouthful. We're subspecialists and we practice physical medicine and rehabilitation. You can also call us physiatrists.
No,
which make us sound like
with psychiatrists.
We sound like psychiatrists, or like it makes us sound like we put bubbles in soda or something. Physiatrist.
Oh yeah.